Welcome to the New Dentist Study Club podcast. My name is Dr. Sanj Mohanta. We're going to learn about clinical management, practice management, and the emotional management of dentistry. Let's learn how to be happier in dentistry. Let's go. Hello, everyone. Thank you so much for joining again on this very special episode on endodontics with endodontist Dr. Farzad Danesh, who is an endodontist in Toronto. And I am so lucky because I got to go to his endodontic course a few months ago and I learned so much. So I wanted him to be on the podcast so that he can share that information with all of you. And then if you're interested at the end, Farzad's going to share his information about his course, and then you can sign up and learn as much as I did during my great experience with Farzad. So Farzad, welcome to the podcast.
Oh, thank you. Thank you, Dr. Sanj, for inviting me, and it's a pleasure with you and to be here. And I say hello to new Dentist Study Club members, and in advance, Merry Christmas and Happy New Year. I'm Dr. Farzad Danesh. I'm a certified endodontist. I practice in North York, Endodontics on Don Mills, and in Richmond Hill, Allegheny Mills Endodontic Specialist. I have been an adjunct clinical professor in University of Western Ontario, Schulich School of Medicine and Dentistry 2011 to 2013. And since then, I have been giving lectures and collaborating with different and several dental education centers like Palmieri Media Group. And lately, I set up my own endodontic course, which is called Pure Practical Endodontics. Pure Practical Endodontics, as the name implies, we focus on the practical aspects on the endodontic treatment, like access cavity, finding calcified canals, preparation, obturation, irrigation, apex locator, and ultrasonic. As a matter of fact, endo is my hobby. And my friends ask me, okay, Farzad, what do you do? I say, I do endo. And they say, okay, you do endo. And then what do you do when you don't do endo? I say, I read endo. And then they laugh and they ask, okay, if you don't do endo and you don't read endo, what do you do? I say, okay, I teach endo. So so endo is I'm actually a little exaggerated. I have a happy life with my family, my friends. I have very good friends. So I'm happy here, and then I'm ready to answer your questions.
Well, thank you for that great introduction. So Farzad, before we get into like all the endo tips, let's start with informed consent because recently I sat in on a endo consult with an endodontist, and his informed consent was like it was fantastic, that whole experience, because he didn't just say like sign this. He didn't just say, okay, your options are extraction or root canal. Like he went into like so much detail. And it was great because then it set up the patient for expectations and they really knew what they were getting into. So tell me, Farzad, what do you put in your informed consent form?
So as you said, informed consent should be comprehensive. It should include everything. For example, in my consent form, because I teach, I included, for example, I'm gonna use your X-rays in my lectures without actually showing your face. But I mean, it's very comprehensive stuff inside. So regarding the consent form, first of all, I tell you, I finalize everything in my consultation visit. For example, if we're going to talk about health of the patient, we're going to finalize. Regarding the cost, we finalize. So when the patient comes, the next appointment for the treatment, I focus just on the treatment. And I actually advise the dentist, finalize everything at the consultation visit. Okay, and I'm going to talk about informed consent. So because in endo, for example, myself, I'll allocate 1 hour and a half for root canal treatment, and every minute counts. I tell the patient, listen, it's not just a matter of the filling. I need to freeze, I need to wait, I need to test before if the tooth is frozen. So for my treatment, every minute counts. So I speak everything, and then on the treatment visit, I focus on the job. Regarding the consent form, as you said, we talk about everything, the options. If the patient want to save the tooth with the root canal, if the patient want to have the tooth pulled, if the patient want to actually to no treatment, I'm actually emphasizing on no treatment. Okay. If the patient opts for no treatment, we need to put down the patient chart that the patient opted for no treatment and he or she knew about the risks and complication in the future. If anything happens, abscess, if there's an apical lesion, abscess, and the patient's okay, you didn't actually offer me no treatment, you actually didn't offer me, you didn't tell me regarding the complication and I needed to know. But I told you I want no treatment, but I didn't know about the complication. But you need to write down the patient that a patient informed about the risks. So the options to do the root canal, save the tooth, to have the tooth pulled, and no treatment. I talk about the risk, at least 3 to 5 complications or risks we need to count. For example, if the curved perforation, pulpal perforation, broken instrument, non-healing, I'm going to talk about success rate, non-healing. We shouldn't promise to patient, okay, you are at good hand. I'm going to do the root canal. It's going to be 100% successful. No, it is wrong. We shouldn't promise to patient 100%. The success rate of the root canal treatment depending on the status of the pulp and preapical, it differs. For example, 60% to 95%. We can't tell, okay, I'm going to do the root canal treatment and it's going to be 100% successful. It is good to be actually tell the truth to the patient. Okay, there's a lesion, for example, based on the studies, the success rate of this tooth is 65% to 85%. But by the way, so talk about the complication and the risks. At least 3 to 5 of them should be included. You'd write down everything in the consent form, but in the patient chart, you need to write it. You can't tell, for example, okay, we discussed in the informed consent. You need to write handing or whatever type in the computer that is a complication. These 1, 2, 3, 4, 5, right? Until the patient know about those main stuff. The risk and complication and success rate. Success is very important because patient comes to say, okay, doctor, you can guarantee 100%. What's my answer? I say, okay, listen, I guarantee 100% of my treatment, the procedure that I'm going to do the good job for you, 100%. I guarantee my job. I cannot guarantee the result. The result actually multifactorial. So don't promise the patient that we're going to be 100% successful. The success of the apical lesion is 65% to 85%, and it could be 100%, but we don't promise the patient. On top of that, we have another term which is called survival rate. Survival rate means that the patient is in function. Patient doesn't have any active infection. There is no sinus tract. Patient is comfortable, functional. The tooth is actually in function. Patient can chew on the tooth, but when you take an X-ray, the lesion is still there. Okay. After 1 year, we take an X-ray. Patient is happy. We change the patient lifestyle because patient before couldn't chew on the tooth. Right now it is functional, but the lesion is still there, right? So we don't jump into the treatment. We monitor. Otherwise, there are symptoms, right? Or otherwise, if the lesion is developing. But even in that case, still we wait. I have lots of cases that, for example, they booked for surgery after, for example, 6 months, the patient came for another consultation and plan because the patient postponed the surgery. And the patient came and we took the X-ray. It healed. But we have already planned for surgery, but patient postponed. So we need to take into account the delayed healing. But I don't want to actually talk about this, but I mean, the survival rate is 98%. They share with the implant. Implant survival rate and root canal treatment is 98%. And on top of that, we can talk about the survival rate. Okay, see, if the lesion did not heal, but the tooth is still functional. We're not going to do anything, we just monitor. So we talk about the survival rate as well. One more important is the filling of the tooth. The tooth should be filled. I tell the patient, listen, after root canal treatment, you need to see your dentist and you have 1 month time to have the tooth filled. But I recommend not to tell 1 month. If they tell the patient 1 month, it's going to actually postpone by 2 months, 3 months, and it can cause problem. But the sooner, the better. I tell 7 days to 10 days, the tooth should be filled, right? And another discussion is for back teeth is placing the crown. I tell the patient are not mine, they're not referral. The dentist is going to fill it, place the crown, but I tell the patient at the consultation visit, this tooth, any back teeth after root canal should be crowned. There is a time format for the filling. It is maximum 1 month, maximum, right? But there is no time format for the crown. The sooner the better. The studies shows that the teeth that root canal treated and crowned, they survived for at least 5 years, right? But those that didn't receive the crown actually has been taken out, extracted because of the fracture before 5 years. So there is no time format. The sooner, the better. Let me see if we can. Yeah. That is the thing. All thing that. Yeah. One more thing regarding the follow up. We need to follow with the patient. I tell the patient, okay, after 1 year, we're gonna actually call you, come over. And one more thing regarding the price. The price that we are giving to patient, we separate. I don't feel the tooth because I'm a specialist, but it's better in your practice. You actually delineate with the root canal treatment cost and the filling cost and crown cost, okay? Because the patient says, okay, it is X dollar, so it included root canal, price for filling, and price for the crown. And make sure that you speak around about this stuff at the consultation visit.
That's excellent, Farzad. Yeah, that was definitely what I was aiming for. You have to talk about the price. You have to talk about, the survival rate that is not 100%, and then go into details of all the complications, reinforce the restoration, like very quickly, and a crown on posterior teeth, because I experience it, and I've seen so many new dentists experience it, where root canal teeth treated teeth fail or break. The patient's very upset. Some of these dentists have gotten complaints. Patients want their money back. They want their retreatment paid by the original dentist, and it becomes a huge mess and a loss of trust. So I learned, like, you have to spend a lot of time with that informed consent. And also, you don't have to do the root canal that day. This is a big procedure. So it's better to do the consult, let them thinking about
Yes,
it, and then have
agree.
them call you to make the appointment.
Agree. One more thing. For example, for cracked teeth, I discuss the cracked teeth. I give the informed consent to them. For apical surgery and consult, I give the informed consent to them. I tell them, okay, I'm gonna send the report to your dentist, but it is the consent form. You're gonna take home, have a coffee, and read it. Talk to your family member, talk to a friend. If you want to phone your dentist to discuss for these two, for root canal treatment if they see that is needed, but for sure for cracked teeth and for apical surgery, I hand in the informed consent and say, okay, go and then think about it and inform me.
Okay, excellent. Now let's go into some of the tips that you taught us during your course a few months ago. So one of them was like for your access, what bird do you like to use?
So no specific bird, I cannot name any specific bird, but because we work under microscope, our birds are long. I use round bird diamond coated, high speed, but I cannot name the number. I can find that later. But there are different birds, but there is no difference. You can actually have your own birds. Even in my course, I inform them, okay, listen, I can provide the birds, but the birds is a preference of your practice. You need to choose yourself. But I can, for example, some of the birds are like this, like that. For example, is taper with the round end. There is no difference. It's just the commercial stuff, I think.
So use whatever is best for you, but you like using the high speed diamond rounder.
Endo actually doesn't cut at the end. But
Oh, and the,
you have been into
okay,
my course. I don't, I you use ultrasonic. We use ultrasonic to actually complete the, but endo actually, because it doesn't cut
Josie.
at the end, you can actually reduce the chance of violating the pop-up floor. But
Excellent.
I can find out, but I'm not into the specific burrs at
Yeah, I
all.
don't know the numbers either, but Endo Z non-cutting tip.
Endo yeah, but for 10 years I don't use Endo burr because I'm using ultrasonic for 25 years.
Okay,
So
easy.
for any case, any single in the single case, I use ultrasonic.
Okay. And then how about where do you sit for your endodontic procedures?
Say that again, doctor.
Where are you seated? Are you at
At
11
12.
o'clock?
12.
I know. I was surprised when you told me that during
Yeah,
the
because
presentation.
because I work
At
under
12,
microscope.
no matter what procedure. Then how about for people who don't have microscopes?
Yeah, but I knew some of the endodontists. They work under microscope. They sit at 8 or 9, but I sit at 12.
And then if you don't use a microscope,
I don't work.
we but for us, like does it but for us who don't have microscopes.
It's same actually spot 12.
Oh, 12 o'clock. Okay.
Before microscope, it goes back maybe to 12 years ago. I have had loops, the same position.
So you like to sit at 12 o'clock.
But
And then
without back home, it was at 8,
okay,
8,
at
9,
eight. Okay.
11.
And then how about for irrigation? Do you irrigate after every single file?
Yeah, irrigation is very important because we need to irrigate, actually have a wet environment when we do the filing. Otherwise, we're going to pack dentin, then opening the pack dentin and dentin mud is very difficult. So irrigation is the inevitable part of the root canal treatment. But it's the main part because with the file, we cannot access the tiny areas. We need to irrigate and agitate and push the irrigant that they comes in contact with the dentin, they come in contact with the microbes to kill them. So by just using the syringe, which is called passive irrigation, it doesn't work. Okay, we need to agitate. We need to open up the coronal part of the canal, irrigate from any action file. Is going to be like this: filing, irrigation, patency, irrigation, and filing. So at any seconds we irrigate, right? And different kind of irrigation and techniques, but we need to agitate. We need to actually make and push the irrigant into the area that I cannot touch with my files. So if you ask me, my filing cleans the canal or disinfects the canal, or my irrigation, I say I irrigation. Irrigation cleans the canal. Irrigation kills the microbe. Irrigation disinfects the canal. And preparation makes room for the irrigation.
So how are we supposed to agitate?
So different ways. Is endoactivator. It's a sonic that from Dens Barcelona, and passive ultrasonic irrigation. Passive ultrasonic irrigation is good, but the tip might break. But based on the studies, sometimes there is difference between passive ultrasonic irrigation and sometimes there is no difference, right? But if the dentist use endoactivator from the Barcelona, that is right now is has a stronger one, I recommend, right?
Activate.
ultrasonic, passive ultrasonic irrigation. They have a wire they can attach to the handpiece head and they can agitate. So even with the gutta percha, if they don't have this stuff, after preparation, for example, they prepared to number 35, for example, okay? They take 35 gutta percha, they put inside the canal EDTA, saline, whatever needed, irrigant, and then agitate actually up and down, push up and down with the gutta percha. It can help. It help, but definitely machine assisted like ultrasonic, like endoactivator is better, right? What I use is laser after preparation or during the preparation in the middle of the treatment. I use laser to agitate, and another device is gentle wave that I don't have, but laser I'm very happy and it really expedites the healing.
Okay, excellent. And then for your irrigant for the sodium hypochlorite, what percentage do you use?
It could be 3 to 8% full.
Okay.
You can I use half, but it could be full strength, but should be very careful of hypochondrial accident to
Okay.
so the syringe, the needle should be loose in that canal to prevent sodium hypochlorite accident. And there are lots of stuff that actually out of the time that we have here. But
And
make sure that it's not locked. The needle is not locked.
and then for our C prep, do you use that on every single file?
Always, and you don't need to dry the canal. While
Okay.
it is sodium hypochlorite is inside, you use RC prep, or in calcified cases, right? You don't need to start with sodium hypochlorite, right? You start with EDTA, right? And then
Good tip.
yeah, and then you switch to sodium hypochlorite because EDTA just lubricates. And after you find in the canal preparation and you switch to sodium hypochlorite. But when you remove the smear layer with any technique, removing the smear layer with laser, with endoactivator, with passive ultrasonic irrigation, is the same protocol. 30 seconds sodium hypochlorite, dry, 30 seconds saline, dry, 30 seconds EDTA, dry, and then 30 seconds sodium hypochlorite, dry, and at the end, saline. Saline is the actual final irrigation. So it's a protocol that you use. But for the calcified canal, you can start with the EDTA and then later on you switch to sodium hypochlorite and then you remove the smear layer later.
Okay, so for calcified canals, start with the EDTA, then go to sodium hypochlorite. Now, you mentioned several passes of different types of irrigants. Do you do that at the end before you obturate?
Say that again?
So you mentioned several different
Yeah,
types of
yeah.
irrigation sequences.
Saline
You
is
do that at
no,
the end?
final.
Okay. So can you go through those passes again? So
Yeah,
you
yeah, yeah.
do,
So it is a protocol for removing the smear layer. A smear layer is amorphous layer that is produced by filing. It's dentin mat. It has two parts. One is calcified stuff, and the other one is organic. Organic should be removed by sodium hypochlorite, and calcified stuff should be removed by EDTA. So what we do, regardless of what we use during the treatment, for example, we use 100 times sodium hypochlorite. Right now, at the time that I need to remove the smear layer, what I do with my actually laser or with endoactivator, with ultrasonic irrigation, right? The protocol is the same. Three times, 30 seconds sodium hypochlorite. So I dispose sodium hypochlorite in the canal, right? And each canal should receive three separate 30 seconds activation with the instrument sodium hypochlorite. So we refresh. So 30 seconds, I refresh, and then 30 seconds, I refresh sodium hypochlorite, and then 30 seconds again. And I dry. Could be with capillary tips, could be with the paper points, and I use saline, right? 30 second activation, and again dry, and two 30 seconds EDTA. I put EDTA, each canal receives two separate 30 seconds EDTA, and then dry and use saline, and again 30 seconds sodium hypochlorite. In the middle, you refresh the sodium hypochlorite, and then dry, and at the end, 30 seconds agitation with saline. It's a protocol, a standard protocol to removing the any instrument that you use. Even with for the laser, I use the same thing. But laser is less time consuming because I don't need to go to each canal. I put my instrument, the tip, in the pulp chamber. But for endoactivator, you need to do one by one, one by one, one by one.
And you mentioned during the course about drying, like to never use the air water syringe to dry.
No, 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 no. Don't do this. So you can use uh, paper points, capillary tip, or your irrigation syringe that withdraw the plunger.
Okay,
Right? Put the needle inside the canal, right? And we actually pull back the plunger. It works. Okay? You can empty the air inside the container, make sure there is no air, right? Put the needle inside the canal and pull back the plunger.
that's good. That's good tip.
Yeah,
Now
yeah.
you also mentioned before obturation, you finish with your rotary files, before you jump to, picking your master apical gutta percha point that you use like a number 25K file.
Yeah.
And you,
It is for gauging the canal. It
okay.
depends. It depends because when I finalize, we final the preparation. We say, okay, preparation is finished. Okay, so we need to gauge the apical part. So if, for example, with wave one at the course, so wave one primary, the tip is 25. Right? We finished, right? We need to verify if the preparation is finished by two ways. Okay, one, using 25 number 25 nickel titanium file, because why we don't use a stainless steel at this actually stage at this point, because if the canal is curved, definitely nickel titanium files goes. For example, it is a wave one, right? It's a gold alloy, it goes. But even if you use 25 steel, made of steel, it doesn't go. So you need to gauge actually the bottom of the apex, at the apex with the 25 nickel titanium file, and you put in the canal and you tap on the top. Tap, tap, tap. If it goes, it passes the apex, right? It shows that we don't have apical stop, we don't have apical sit. So we need to go, if the anatomy allows us, we go to the next file. For example, we need to prepare with the wave one medium, which is gauge, which is actually green, right? We prepare because right now we know that the 25 that we use, is smaller than the prepared the canal, because it was a fit, it go past the apex. Right now when you tap on it, it passed the apex. It shows that the canal is bigger than the file, right? It's one criteria. The other criteria, when I remove the file from inside the canal, I'm look at actually the apical to 3 millimeter. I see if I see debris or not. If I don't see debris, so there was no engagement, so it doesn't work. So I need to, if the anatomy allows me, okay, it's not going to be like this. Okay, Dr. Danish told me go ahead, and no, you might perforate, right? If it's not possible, if with the preparation with the wave one medium, you see it doesn't go because of the curvature, don't do this. Okay, go back, prepare a little bit more, a little bit with your previous file. Use, for example, hand files. nickel titanium, okay, instead of using rotary or reciprocating, and clean. And make sure you clean with the endo activator, right? So we in this case it's going to be a little bit compromised, but it works.
A good tip. Yeah. But after your instrumentation, put that 25 nickel titanium hand file down, tap on it, and if it goes past the apex, then you're going to have to move up to the green wave one. And
Right.
you should have green at the tip of that K file because you're engaging the apex.
Yeah. But if it was not possible to go to the next file, okay, we control the length of the actually filling by cutting back the tip of the guttapercha, wave one guttapercha primary that we have been using, right? Because we are controlling the length of the obturation by cutting back the tip of the 25 so that we are at the exact length and we have tug back. Tug back is very important because, for example, right now warm vertical compaction is gold standard, okay? And we need to have a very good tuck back.
Okay. So you were saying that if we can't move up to the wave one green, then to cut the tip of the
We control the obturation length by cutting
primary.
back yes.
Okay. Good. And you gave a couple of good tips also. Like I'm used to holding the files with my fingers, but you use something else. You use it's
File
like a
holder.
file holder.
Did you
That
did
was
you
great.
try that?
Yeah, I did. It was
Really?
so much easier. Yeah.
Yeah,
So
yeah,
yeah,
yeah.
use the
It's
file
very
holder.
it's file holder from Clinical Research, London, Ontario. I love it because even with that one, I do actually a little bit preliminary preparation in the beginning. I don't need to actually use my finger. I use that one and it gives me enough room to see where I'm placing my file.
Yes.
You know,
Yeah,
you
so
know
it's
the
like
curve,
cotton pliers, but it's a file holder.
this file
Yeah.
holder, and I curve, for example, if I place for upper molars for mesial canal, I curve to mesial, and I actually it should be the tip of the file toward the mesial, and it really helps. I'm
So
happy,
you use the
I'm
file
happy that you
holder
say you use
to
it.
bend. Yeah. So you use the file holder to bend the tip of the file. You don't use your
No,
finger.
no, no. I used to it. I use actually cotton plier, but you can use you by pressing the tip of the file toward the actually rigid surface. But I used to it actually 35 years. I use
Yeah.
cotton plier, but don't touch the tip of the file at all. If my assistant touches the file, I say, listen, put it aside, give me another one. Don't touch. If you want to touch it, use a sterile gauze.
Okay.
Don't touch.
So don't touch
Don't,
the
don't
tip.
do actually bend with your finger. No, no. With the cotton plier or by pressing toward the hard, actually rigid surface, or actually using a clean, sterilized gauze.
Excellent. Wow, you gave us a lot of great tips. And my final question is like, to, in order to do good endodontics, do we need CBCT, the microscope, the endo activator, the gentle wave, like all these things? Because I feel like I should just refer all my endo to endodontists because I don't have those things. So, what do you think about general dentists doing endodontics without those?
They can do that definitely.
Okay.
Without those stuff, still we can render high quality treatment to patients, and we are at the level up which is acceptable. Okay.
Okay.
So without microscope, without CT scan, without endoactivator, still we can do, we have been done before. Lots
Yeah,
of
that's right.
success. We can do that. But the point that we need to stick to the essential policy and principle of endodontics. What does it mean? Accurate diagnosis, rubber dam is very important. Preparation, not missing any canal, knowing the anatomy, knowing and obturation and filling and coronal seal. If we stick to this stuff, we are very much successful. So, by the way, we have CT scan. Why we shouldn't use? If we have opportunity to use it, we use it, right? If we have microscope, but it doesn't exclude loops. Loops is needed. It is necessary. We can't tell that, okay, Dr. Danish told me, okay, without this, no, you need loops, right? You need to use magnification. You need to have illumination, enough light, enough magnification. But if you don't have CT scan, but if you have, you know the anatomy, right? If you know the anatomy, okay, I use CT scan, right? Because I have it. But if anybody doesn't have CT scan, they can actually send for CT scan, or by increasing their knowledge. For example, I know that 80%, 70% of upper molars has MB2. So I should look for MB2, but it doesn't actually hinder them from actually rendering a actually high quality treatment. So CBCT, microscope, endoactivator, right? If you have, is perfect, or you can stick 100% to the principle of endodontics, and I promise you it's going to be very good treatment, a high success rate.
Oh, great. Thank you, Dr. Danish. That was excellent. Thank you for all of your tips. I can't wait for part two when you talk about
Thank
endodontic
you.
complications. I really appreciate it. Can you share with the audience how they can contact you?
So, yes, Elgimis endodontic specialist, endodontics and dummies, and pure practical endodontics. If you Google them, they can find easily. And my next course gonna be in January 25th, and the hands-on gonna be February 1st. And then we discussed actually comprehensive discussion, those stuff regarding the practical aspects of endodontics.
Oh,
You
great.
know,
So,
new dentists will have 20% off.
woohoo. Yeah, sign up for Pure Practical Endodontics. So Dr. Danish has for us in Toronto at the end of January and beginning of February. And if you say that you're a member of the New Dentist Study Club, like if you join our club, you can join us on Instagram. The link's in the bio. You get 20% off. So thank you for that generous discount. And thank you so much for your time and all of your tips. You've helped me with my endodontics. You've helped so many members of our club who have gone to your Pure Practical Endodontics course. So I appreciate it. So thank you very much, Farzad.
Thank you very much for your time, Dr. Sanj. I really thank you, and it's a pleasure. You know, I love teaching, and then I always, in my 35 practice, I share always my knowledge with the dentists. My pleasure.
Yeah, yeah, thank you. And thank you to the listeners for tuning in. Stay tuned for the next episode. Bye, everyone. Thank you for listening to the New Dentist Study Club podcast. Follow us on Spotify, Apple Podcast, and YouTube, as well as our Instagram page at New Dentist Study Club. Check out our link in bio, and you can register to be a member and attend one of our live in-person events in Toronto. Thank you so much for listening. Please share this episode with your friends and stay tuned for our next episode.